Hello. Thanks to Path Presenter for this soft tissue case. It's a leiomyosarcoma that has metastasized to the femur. From low power, I don't see trilineage hematopoiesis if we were sampling the bone marrow of the femur. What we do see are very cellular bands and regions, swaths of cells. We look closer, they kind of have this vesicular architecture and it's at different orientations. That's why you can see the side profile of here, where it's kind of like streaming and vesicular. And here, maybe it's coming at us or coming into the screen. But here you can better see the side profile of the streaming architecture. And this in smooth muscle, we like to describe the architecture as like a school fish, and you could kind of see the resemblance of the school fish. But in this case, this has gone bad. It has undergone a lot of genetic mutations that has increased its replicative and capacity, and it just looks really it looks anaplastic. It looks very atypical, very high NC ratios. I like to use my handy dandy like red blood cell as a way to compare the tumor cells. So like this red blood cell with this tumor cell, maybe those are two that are next to each other, but look how large these cells are and how different they are from each other. Very pleomorphic. And so this is a leiomyosarcoma that has metastasized to the femur. Leiomyosarcomas of the uterus, they're the most common sarcoma in the gyne tract. It's important to know that there are three types: conventional, epithelioid, and myxoid. And the reason why is they have different diagnostic criteria. For the conventional, you need two of three. Significant cytologic atypia, which we fulfill here. Coagulative necrosis, which I don't see in this metastatic specimen, and greater than or equal to 10 mites per 10 high power fields. However, for myxoid, you only need one criteria, and that could be either greater than or equal to 4 mitotic figures per 10 high power fields. It could be marked cytologic atypia, it could be tumor cell necrosis, and it could be infiltrative borders. And then epithelioid leiomyosarcoma, you also, if there's any significant cytologic atypia, coagulative necrosis, and this one is greater than or equal to 4 mites per 10 high power fields. So that's why it's important to distinguish. So this is a conventional leiomyosarcoma, and leiomyosarcomas in general have poor prognoses. And they're not driven by one particular genetic alteration or translocation. And that helps explain why it looks so atypical and not monomorphic. It's tumors with just monomorphic one translocation tend to be uniform and bland. But this has so many genetic alterations and genetic heterogeneity that these cells look different from each other because they just have different mutations. But some common ones include TP53, ATRX, MED12. And usually patients who have this don't have predisposing factors. And again, just to point out how bad this prognosis is, the 5-year overall survival is around 15 to 25%. So this would stain for Desmond, but Desmond can also stain skeletal muscle as well. So you can also do an HCal Desmond, SMA, and that'll also stain these smooth muscles. One last thing is my gyne staff has taught me like leiomyomas too have mites, and they can be cellular leiomyomas. They can have a lot of mites. And what's more important for leiomyosarcomas, just because they undergo so many genetic alterations, having an atypical mitotic figure like a Mercedes-Benz sign. If you don't know what I'm referring to, is like a mitotic figure that is literally, it looks like a Mercedes-Benz sign. Those atypical mitotic figures are more, keeps you on your guard for this is a either a stump, a stromal tumor of uncertain malignant potential, or a leiomyosarcoma. So here's a mite that we can see here. Anyway, yeah, this is a leiomyosarcoma, and I'll see you all next time.